Okay, good morning class. This is your hematological alterations lecture. This is part of your Module E lecture, which goes over the cardiovascular system. So to begin with the hematological system, first we need to know where red blood cells come from, or where our blood cells come from. And our blood cells come from the bone marrow, and the bone marrow is the central core of our bones. And so the bone marrow is responsible for the production of three types of blood cells. We have the erythrocytes, which are red blood cells, the leukocytes, which are white blood cells, and platelets. The above make up to 45% of our total blood volume, the erythrocytes, leukocytes, and platelets. So there are certain disorders or diseases, and you've probably read about those in chapter 31. When the bone marrow is affected, then that individual will have problems with the production of red blood cells, white blood cells, and platelets. When you get into your upper division courses, you'll learn about diseases like multiple myeloma and leukemia. And with these disorders, it's when I like to say a part of the body is sick. But with these type of disorders, the bone marrow is sick. And so we see here that the bone marrow has a job for producing our red, white blood cells and platelets. So when the bone marrow is sick, it's not able to adequately produce these blood cells. And this is just a picture showing you a blood cell, the bone marrow, and the blood cell components that are associated with it. And so for this module, we're specifically going to be focusing on erythrocytes. As I said before, in your upper division courses, you're going to focus on white blood cells, and you'll also get into platelets in your upper division courses. You'll talk about thrombocytopenia in 201, and you'll also talk about it again in 202. So for the purposes of this module, we will not focus on platelets. We will only focus on erythrocytes. And so with erythropoiesis, this is the production of erythrocytes. Erythropoiesis is the process of growing red blood cells. And erythropoiesis is stimulated by hypoxemia. And so we know hypoxemia means we have low oxygen levels in the blood. And so when the blood senses that the O2 levels are low, then erythropoiesis starts the production of red blood cells. And this process is controlled by the hormone erythropoietin, which is produced by the kidneys. So again, we see the kidneys playing a part, playing an important part in our body, in that if the kidneys are sick, then we can have red blood cells manufactured. When you have your lecture again in your upper division course, and you're talking about patients that are on dialysis, anemia is a problem that we see sometimes with our dialysis patients, because the kidneys are sick when patients have renal failure, so it's not able to perform its normal job or activities. And so one of those jobs is the production of erythropoietin, so that we can have red blood cells manufactured. Also, the production of red blood cells is influenced by nutrition. We have iron. Iron plays a really big part in the production of red blood cells. Iron is needed for hemoglobin synthesis, and we're going to talk more about hemoglobin in this lecture. But what I want you to make sure you pay attention to, I want you to go to page 678. It's chapter 30 in your book, and it's a chart that talks about the different lab values associated with your blood cell components. And particularly, I want you to make sure that you commit to memory for this exam the normal hematocrit and hemoglobin levels. As I said, iron is needed for hemoglobin synthesis. Hemoglobin is a portion of the red blood cell, but we have to have iron in adequate levels for hemoglobin to be manufactured. So Iron is really important to the diet. Also, vitamin B12 is needed because vitamin B12 also is responsible for hemoglobin synthesis, or the manufacturing of hemoglobin, as well as folic acid. Folic acid is needed for red blood cell maturation. So we know when we mature, then we're getting bigger. So I made a mistake with vitamin B12. Vitamin B12 and folic acid are both needed for red blood cell maturation, or the growth, the full maturity of a red blood cell. Going back to hematocrit again, as I said, it's on page 678 in your book. And so with hematocrit, if you can commit this to memory, hematocrit is looking at a percentage. And so the percentage that we're looking at is the percentage of red blood cells in the total blood volume. Now, the previous slide talked about the three blood cell components. We have white blood cells, red blood cells, and platelets. So the hematocrit is looking at what percentage of the total blood volume is red blood cells. And so the hematocrit, again, as I said, is a percentage, so that should be easy, should help you to remember for testing purposes. But for women, normal hematocrit is 38 to 47%, and for men, it is 40 to 54%. Well, when we look at hemoglobin, the hemoglobin is a measurement of the gas carrying capacity of a red blood cell. Now, again, I said that the red blood cells, hemoglobin is a part of the red blood cells. Our hemoglobin is responsible for carrying oxygen and also carbon dioxide. So, when we look at hemoglobin again, we're looking at the capacity of that red blood cell's gas carrying capacity. So in women, this value is 12 to 16 grams per deciliter, and in men, that value is 13.5 to 18 grams per deciliter. So again, make sure that you go back and look at those labs. The hemoglobin molecule is also responsible for playing a part in the buffer system. And we learned about the buffer system when we talked about fluid and electrolytes. And we know that the hemoglobin molecule was responsible for regulating our acid-base balance, and that if a person were too acidic, then that heme molecule would take away hydrogen molecules, and if the person were too basic, then the heme molecule would add hydrogen molecules. With erythrocytes, they have an average lifespan of 120 days, and so when we look at the hemoglobin again, this is the iron component of the red blood cell, and its purpose is to carry oxygen. Again, the hematocrit measures the packed volume of red blood cells, the percentage of red blood cells in the total blood volume. And when we look at the ratio of hematocrit to hemoglobin, it's 3 to 1. And if you go back and look at the lab values that I just told you, for a woman, a hemoglobin is, let's say, 12. We're looking at 12, but the hematocrit is 38. So we see that that hematocrit is 3 times that hemoglobin. Hemolysis is a normal process that takes place in the body. Hemolysis is the destruction of red blood cells. Old red blood cells are to be destroyed every 120 days. The spleen removes old and defective red blood cells, and the spleen is also responsible for filtering out microorganisms. With excessive hemolysis, however, a person develops jaundice, and jaundice is a yellowing of the skin, and what we have here is that the spleen is overdoing its job, and it's breaking open too many red blood cells, and so the components within that red blood cell now spill fill out, and the person takes on this yellowish tinge or this jaundice color, and it's because too many red blood cells have become destroyed or hemolyzed. With the lymphatic system, we have lymph nodes, and the purpose of the lymph nodes are to filter debris from the lymph and to produce lymphocytes. We have the tonsils. They produce lymphocytes and antibodies, and they act as a trap for bacteria. And then we also have the thymus. They're useful in the development of T lymphocytes, and they're responsible for cell-mediated immunity, and you'll learn about that again in your upper division. But the T lymphocytes play a part in our immune system in that they directly kill microorganisms that come inside the body. The spleen, again, the functions of the spleen are to store up to 1 pint of blood for emergencies. They form lymphocytes, monocytes, and plasma cells. They break down the spleen breaks down old RBCs, and it also removes bacteria by phagocytosis. The diagnostic test that we'll talk about for the hematological system is the complete blood count. The components of the CBC are the red blood cell count, the white blood cell count, hematocrit, and hemoglobin. Also, we look at the erythrocyte indices when we do a complete blood cell count. We're looking at the size, the shape, and the color of the red blood cell, and we're also looking at a differential white cell count when we do a CBC. We look at a differential white cell count because we have different types of white blood cells. We have lymphocytes, monocytes, macrophages. We have neutrophils, eosinophils, basophils. All of these are different types of white blood cells. So within a complete blood cell count, we're also getting a differential white cell count and looking at the different types of white blood cells. With anemia, within this module, we're going to talk about the different types of anemia. So, anemia overall, you have the RBCs, the hemoglobin, and the hematocrit levels are below normal levels, are below normal when we have a person with anemia. You may also see decreased serum iron, decreased total iron binding capacity, and decreased serum ferritin. Ferritin is also a measurement of iron in the body. And a person will have insufficient oxygen supply to the tissues with anemia, and that makes sense because we said that the red blood cells are responsible for carrying oxygen throughout the body. So when we have a person that's anemic, then they have a decrease in their red blood cells, and so they're going to have a decrease in the oxygen that's going to be delivered to their tissues. Some terms that we have to look at when we're talking about anemia are macrocytic, normocytic, and microcytic, and all of these refer to the size of a red blood cell. When we're looking at a macrocytic red blood cell, this is a red blood cell that's large in size. A normocytic red blood cell is normal in size and color, and then you have a microcytic red blood cell that is small in size and also pale in color. There is a chart on page 686 that talks about the relationship of the morphologic classification and etiologies of anemia. Make sure you look at that, and also look at the clinical manifestations of anemia. This is also a chart on page 686. When we look at the normochromic and hypochromic red blood cells, this refers to the hemoglobin content of the red blood cell and the cell color. So again, when we look at microcytic, normocytic, and microcytic, we're just looking at the size of the red blood cell. But with normochromic and hypochromic, we're referring to the hemoglobin content and the cell color. So the symptoms that we see associated with anemia, the symptoms are the result of decreased oxygen carrying capacity to the cells, and so the person is going to have fatigue. They may be pale in color or have pallor. The person is going to be dyspneic or short of breath, and that makes sense because the person has decreased oxygen. The person may also have tachycardia. Tachycardia because the heart is hungry for oxygen, and so when the heart senses, we talked about low cardiac outputs, the heart is going to pump harder to try to get its oxygen needs met, to get more blood circulating. The person may also have vertigo or dizziness. They may complain of a headache. The brain cells are being starved of oxygen, and they may also have cardiac dilation. And we talked about constriction and dilation, constriction, but now that heart is dilating because it's hungry for oxygen, so those cells of the heart are dilating to try to take in oxygenated blood. And of course, the person is going to be disoriented or a little bit confused because of their lack of oxygen. The types of anemia that we're going to discuss are hypovolemic, this is blood loss anemia, pernicious anemia, aplastic anemia, iron deficiency anemia, and sickle cell anemia. With hypovolemic anemia, this is an anemia that's secondary to hemorrhage or to blood loss. Maybe we have a patient that's returned from surgery and they have internal hemorrhaging. Maybe this is a person that sustained traumatic accident and they have a large blood loss. And so what we have here when the person has hypovolemic anemia, they have a decrease in blood volume. And so we have a decrease in the amount of oxygen that's being circulated to the tissues. It's usually due to an acute blood loss, and we may see the symptoms of hypovolemic shock associated with hypovolemic anemia. And so our treatment for hypovolemic shock is to control bleeding. We also have to treat for shock. And we won't go into much detail with shock because you will discuss that later. But with shock, shock develops because the person does not have blood circulating adequately to throughout the body. And so what we have to do with shock, we have to replace lost fluid volume. And so before we can get blood, we're going to get this person some fluids. We've got to get the person's fluid volume back up to an adequate level. We may also do a blood transfusion, and we want to administer oxygen to correct the hypoxemia. If you ever have a patient that is losing blood acutely and they're in your care, we want to go ahead and start oxygen immediately, because we know that if they're losing blood, they're also losing oxygen. So it's simple for us to insert a nasal cannula and give the person oxygen. Pernicious anemia is the absence of intrinsic factor, which is secreted by the gastric mucosa. And so the purpose of the intrinsic factor is without the intrinsic factor, the person cannot absorb B12. Well, we said that B12 is responsible for the maturation of red blood cells. So if the person doesn't have B12, then their red blood cells can't mature and grow to an adequate level to circulate oxygen. It is also referred to as a megaloblastic anemia. And so the etiology of pernicious anemia, with the elderly person, they may, not all people will develop this, a gastric mucosa atrophy. Whenever something atrophy, it draws up. You may hear of a patient having a muscle atrophy, and when the muscle atrophy, it draws up and it becomes smaller than it used to be. And so when a muscle atrophies, a person can't use that muscle adequately because of the decrease in the muscle size. And so when the gastric mucosa atrophies, then it becomes smaller and it can't do its normal perform its normal functions. There may also be an autoimmune component associated with pernicious anemia. Whenever you see autoimmune, that means that the body is attacking itself. We know that the immune system is responsible for fighting off the bad things that try to attack us. Well, with autoimmune, this is the body attacking itself. Gastric surgeries or gastrectomies. We have a lot of patients now having gastric bypass surgeries and different types of surgeries that affect the size of the actual gastric muscle. And so when a patient has gastric surgery or a gastrectomy, they're taking that ability away of that gastric muscle to produce the intrinsic factor. And also malabsorption disorders could cause a person to develop pernicious anemia. And so the symptoms that we see associated with pernicious anemia, the person may have a red, swollen, or sore tongue. And so that should stick out to you right now and be one of those red flags. A person having a red, swollen, sore tongue, we typically see this being associated with pernicious anemia. The person may have impaired position sense. When we look at a position sense, this is just looking at a person's awareness of their posture, and this is the person being able to, I guess to say that this person is enabling the body to orient itself in space without visual clues. And we'll go more into that when we talk about the neurological system. Also, the person may experience numbness and tingling of the hands and the feet. This is referred to as paresthesias, and they may also have disorientation associated with pernicious anemia. And so the treatment for this disorder is that the person is going to have to take monthly vitamin B12 injections for life, because they don't have the ability to produce vitamin B12 in the body, so they will have to take these injections for life so that their red blood cells will mature adequately. If it's severe, the person may also require a blood transfusion, folic acid supplements, and also the person may require iron supplements. And we talked about those things again. Folic acid also helps with red blood cell maturation, and iron is needed for hemoglobin synthesis, or the manufacturing of hemoglobin. With aplastic anemia, this is a condition of decreased bone marrow function. So when we have a problem with the bone marrow, not only are the red blood cells affected, but the person is going to have a problem with white blood cell function and platelet function. And so pancytopenia is when all three major blood elements are reduced. And so we can see right here, this person with aplastic anemia is going to be in a little trouble. They're going to have decreased red blood cells. They're also going to have leukopenia. And so we won't go into detail, but we all know that the white blood cells are responsible for fighting off infection and fighting bacteria and things. So here with aplastic anemia, then the person is going to have a problem fighting infection. And if their platelets are low, our platelets are responsible for helping us to not bleed, and so the person is at risk for hemorrhage when their platelets are low. With aplastic anemia, this is we typically see that it can be congenital. It can also be an autoimmune disorder. This is the body attacking the bone marrow at this point. It may also have be connected to a viral cause. In your book on page 693 is where it discusses aplastic anemia, and so it says here that approximately 30% of aplastic anemias appear in childhood, and then with the acquired aplastic anemia, this is the person, they didn't develop it congenitally, but they acquired it. It may be related to things such as radiation, certain medications, different types of anti-seizure agents, anti-metabolites, antimicrobials, according to your book, can put a patient at risk of developing aplastic anemia. And viral and bacterial infections such as hepatitis, the parvovirus, and biliary tuberculosis all put a patient at risk for developing aplastic anemia. And also chemotherapy. Chemotherapy, I know most have heard of chemotherapy, but we give it to cancer patients, patients that have cancer. And so the purpose of chemotherapy is to kill cells. And so with its killing action, it kills bad cells, those cancerous cells, but it doesn't stop there. It also kills good cells as well. And so when you have a chemotherapy patient, they're at risk, at a high risk of infection, because their blood cell levels have been decreased as a result of chemotherapy. So, how do we treat aplastic anemia? Well, we've got to find and treat the underlying cause. If it's a viral or bacterial infection, we want to try to treat that. Now, hepatitis, as I know, does not have a cure, may be controlled, but I've yet to see or hear that there's a cure for it. We can treat the tuberculosis if it's because of the anti-seizure meds or the anti-metabolites. We may need to discontinue those drugs and find another type of medication. Of course, if it's congenital, there's nothing that we can do about that. That's a non-modifiable risk factor. But with these other things, if it's a chemical agent, if it's radiation that the person is being exposed to, then they may need to change their environment. They need to avoid all blood transfusions if possible to minimize the risk of tissue rejection. Now, this comes more into play when the person has an autoimmune cause for aplastic anemia. With aplastic anemia, our treatment of the patient is directed at preventing complications from infection and also from hemorrhage. So, again, with avoiding all blood transfusions, this is if it is determined that the person has an autoimmune cause for the aplastic anemia. Again, with aplastic anemia, if it's autoimmune, that's the body attacking the bone marrow. So if we give this person a blood transfusion, the body is going to attack it. So we want to minimize the risk of this tissue rejection. So we want to avoid, if possible. The person may need a possible bone marrow transplant. Your book talks about hematopoietic stem cell transplant. When you see the word hemat or the prefix hemat, is referring to blood. And so we've probably heard about stem cells in the media before. Stem cells, once you give a person stem cells, it's supposed to grow, automatically graft and grow what the person is missing. And so if we give a person a stem cell transplant, it's given to help manufacture the blood cells that the person is missing. And so we said that this person needs red blood cells, white blood cells, and platelets. We can also give the person a platelet transfusion. Just like with a red blood cell transfusion, with the platelet transfusion, we also have to make sure the person is typed and crossed to make sure that there's no rejection of the blood cells. But again, we with this anemia, we are trying to control complications because the person is at risk for infection because of the lack of white blood cells, and they're also at risk for hemorrhaging. So we're trying to control these complications with this type of anemia. So make sure you do a good job of reading thoroughly through this chapter. Also, something that I think will help you to pull the loose ends together when you're reading this. Many times in an effort to finish reading, we ignore the charts. I cannot stress to you enough how important it is to read over these things. If you'll look at the nursing care plans associated with the anemias, for example, 688 and 689, it tells you the different types of manifestations that you will see associated with each one of these disorders, and it will tell you the nursing actions responsible for helping each one of those manifestations. And so really these charts just help to pull it all together. And so now when we're looking at an application test and is asking why would you do A, B, or C, you understand why this is the best thing to do and how it's going to what's going to be most effective in treating this patient. So please make sure you read over the nursing care plans and all of the charts and tables that are associated with the information in your chapters. If untreated, aplastic anemia is fatal 75% of the time, and so that's really sad. But again, this person is probably going to die because of an overwhelming infection. With iron deficiency anemia, this is when we have a problem with hemoglobin. The RBCs contain decreased concentration of hemoglobin. So again, we have the RBCs and the red blood cells, and hemoglobin is a portion of the red blood cells. And so again, we know that the hemoglobin, you have a hemoglobin molecule. So if you imagine a box in your head and draw the word heme inside of it, each point on that box has an oxygen molecule attached to it. And so the red blood cells have those hemoglobin molecules that circulate that oxygen throughout the body. And so some possible causes that we see for iron deficiency anemia: if a person has an acute or chronic blood loss, such as menstrual bleeding with the GI bleeding, many women will have to take iron supplements because their blood loss is so great during their menstrual cycle. And again, if we don't have that iron, if we're losing iron because we're losing so much blood, then the iron has to be replaced, or the person will develop iron deficiency anemia. Poor iron absorption from the GI tract. The person may have some type of malabsorption disorder, or poor dietary iron from the diet. And so most of the iron that we take in will be from our diet. And so the symptoms that we see associated with iron deficiency anemia: the person may have glossitis. Pallor glossitis is a smooth tongue again. This person is going to have fatigue, weakness, shortness of breath. They may develop spoon-shaped fingernails, and they may also have tachycardia. And remember, again, we're saying we understand now the relationship of hemoglobin and iron. If I don't have iron, I don't have hemoglobin being manufactured the way that it needs to be. So if I don't have hemoglobin, I don't have oxygen being circulated the way it needs to be. Again, the person may have adequate red blood cells, but the red blood cells are missing its components to be effective, which is the hemoglobin. So again, the heart is going to pump a little bit harder because, again, it's deprived of oxygen. with our diagnostic findings with iron deficiency anemia, the person may have a low serum iron level. They may also have a decreased red blood cell count, decreased hemoglobin, and decreased hematocrit. Okay, because we don't have iron, then we don't have those hemoglobin molecules being manufactured, and it may also affect the manufacturing of red blood cells as well. So our treatment of iron deficiency anemia, well, we're going to give the person oral iron, ferrous sulfate. It can be divided in daily doses. We want to give the person orange juice. Orange juice has vitamin C, and so vitamin C helps with the absorption of iron. Oral iron may cause abdominal discomfort and constipation. Constipation is typically what we hear complaints of with iron supplements. So a person that is taking iron may also be given Colace or stool softener to assist with constipation. A person may be given a IM iron injection, but we want to give the Z-track method. If you remember that from pharmacology, when we give a Z-track, give something by Z-track, we're trying to administer it deep into the muscles and seal that medication in because it burns the muscle. Teaching with oral iron may cause stools to become black. Make sure you tell your patient this. Some people may have heard of GI bleeding before, and sometimes if you have some old blood, it could cause the stools to become black. And so this may alarm your patient. So you may want to let them know that the iron is going to cause the stool to become black in color. Also, oral iron in the liquid form can cause staining to the teeth. So you want to make sure this person uses a straw. With sickle cell anemia, this is the most common genetic disorder in the U.S., and it's predominantly seen in African American patients. Typically, if you have two individuals that have sickle cell trait, that's not the full sickle cell anemia. If they have trait, and you have a woman and a man, both have the trait, the probability of their child having sickle cell anemia is very, very high. With sickle cell anemia, this is a development of an abnormal hemoglobin S molecule in the place of the normal hemoglobin A molecule. Hemoglobin, as a result, becomes crescent-shaped or sickle-shaped when a person is deprived of oxygen. The red blood cells clump, and they are trapped in the small vessels, and they cause pain. And it makes sense because you have the clumping of the clumping of red blood cells. Normally, red blood cells, and you can see here with sickle cell anemia, you see the concave, the sickle-shaped red blood cells. Normally, the round red blood cells, they just brush against one another and they flow on through the body. Well, with these spoon-shaped red blood cells, they clump together. Okay? And so, as this previous slide says, then they clump and they block the small vessels. So if the small vessels can't get oxygen, then it's going to cause this person to have pain. When a person has sickle cell anemia, the blood circulation is viscous, which means that it's very thick and sluggish. The person has abnormal cells. Abnormal cells are recognized and they're hemolyzed. The spleen is doing its job. The spleen functions to remove red blood cell debris from the circulation. And so, with a sickle cell crisis, this is due to increased sickling and deoxygenation. We have an increase of these blood cells clumping together and deoxygenation. A sickle cell does not carry oxygen appropriately. And so when a person has a crisis, then it makes sense that deoxygenation is going to be a problem. You have these sickle cells that clog the small arteries, which is a problem. You have local hypoxia, local tissue hypoxia, and you also have thrombosis as a result of these blood cells clumping together. It occurs due to anything causing hypoxia. So if the person has an infection, it can cause the person to develop a crisis. If they're dehydrated, anytime we take water away from something, let's say we were, cooking a pot of beans and all of the water drained out of them. Those beans are going to clump together because they don't have any fluid. And so that's what we see with dehydration. When a person is dehydrated, well, all the cells clump together because we don't have the fluid in there to break those cells up. So if a person is dehydrated, then it can bring on a crisis. When we travel high altitudes, if you go high up in the mountains, for whatever reason, the air becomes thinner and we have to breathe harder to take in oxygen. Well, that can lead a person to becoming hypoxic if they can't tolerate high altitudes effectively. And so again, the hypoxia can cause those cells to be deprived of oxygen, and can also bring about a crisis. The symptoms that we see associated with a crisis: the person is going to have jaundice from excessive hemolysis. Again, the spleen is overactive when a person has sickle cell disease, and so we have red blood cells being destroyed at a high rate. Some patients that have sickle cell anemia, they have a yellow tinge to that sclera, and it's yellow all the time, and this is something that's pretty diagnostic of sickle cell anemia patients, the yellowish tinge to the sclera. They may also have splenic enlargement. The spleen is enlarged because it's taking in all these red blood cells and continuing to destroy them. The person is going to have pain in various parts of the body, and I've had one of my I've taken care of many sickle cell patients before, and they'll tell you to be careful with the arm because that's the part of the body where they're having their crisis. And so what that means is that they have more cells clumping in that area of the body, and that's the part of the body that hurts them the most. And they're also going to have fatigue associated with it. Our treatment for the crisis is really bed rest. We're going to give the person hydration to help thin the blood, to help break up those clumping cells. We may also give a blood transfusion because if we've got the spleen destroying good blood cells, bad red blood cells, we need to replenish the body with some good red blood cells. A drug is given hydroxyurea, and it increases fetal hemoglobin levels, and it helps to reduce hemolysis, or the breakdown of red blood cells. Currently, there's improved prognosis for sickle cell anemia with bone marrow transplantation from a HLA match, and that's a histological match, maybe from a sibling that has that's the same blood match as the person. But this is something that I'm thinking that's still being researched, but it's real promising for sickle cell patients. It's not a disorder that is that can be treated with age. People with sickle cell, born with sickle cell, will die with sickle cell. Not that they'll necessarily die early, but it's something that they will be affected with. It's a lifelong disorder. Polycythemia vera is an abnormal increase in the circulating number of red blood cells. We see here that with an abnormal increase, it's possible then to have too many red blood cells. And so the two types we see, a person can have a primary the primary type of polycythemia vera, which is all bone marrow elements are increased. So we've got too many red blood cells, white blood cells, and also too many platelets. And so with secondary polycythemia vera, this is secondary only to hypoxia, and so only the red blood cells are going to be increased with this type. And so with polycythemia vera, we see that the blood is going to be very viscous, or very thick. The person is going to have an increased red blood cell, hemoglobin, and hematocrit level. The treatment for this, we want to give the person adequate oxygenation to prevent hypoxia. The person may need repeated phlebotomy, and so when we do phlebotomy, we're taking blood away from a person, and so this is to decrease the blood viscosity, and the person may need myelosuppressive agents. Myelosuppressive means that we're suppressing the bone marrow, and so we're doing that to slow the bone marrow's production of the blood cells. Now, let's go back to the secondary causes again. A reason that we could see a person develop the secondary cause, again going back to altitudes. If a person were to travel, maybe do some mountain climbing or travel up to another altitude, the person is going to breathe, maybe breathe faster to take in oxygen. Well, the body senses that as the person needing more oxygen, and so the body's way of producing oxygen is through erythropoiesis, because we know that the red blood cells are gonna carry oxygen, and so when the body senses hypoxia, then it's gonna produce more red blood cells to then carry more oxygen. So this is why the person is going to need adequate oxygenation to prevent hypoxia. If this were a person maybe traveling up high altitudes, maybe they need to control their breathing so that the body doesn't start to manufacture those red blood cells at a high rate. In your book on page 700 is where it discusses polycythemia vera, and it talks about the manifestations being associated with polycythemia vera. You see it being related to the hypertension associated with it. Now, we've talked about the blood, the heart, and having to pump large blood volumes, but think about if the heart has to pump something that's really thick. And so again, we see a heart that's having to pump harder. We may have some increase in the blood muscle as well, but you're going to see that the person is going to develop some hypertension due to the hyper viscosity of that blood. The person may also have headache and vertigo, and there are quite a few signs and symptoms that you may see associated with this. And again, this information is in your book on page 700. With lymphangitis, we know when we see itis, we're looking at an inflammation. So it's an inflammation of the lymphatic channels that usually result from an acute staph or strep infection in an extremity. The symptoms that we see associated with it are generalized edema. The person may develop a systemic infection, chills, and also localized pain. And so the treatment for this may be penicillin or warm soaks. we talked about the lymphatic system, but we know the lymphatic system has a purpose. It's to eliminate waste products from the body. And so if a person has a inflammation in that channel, then that particular part of the body can't eliminate bacteria effectively. There's a chart in your book, there's a diagram in your book, I want to say it's in page 30, that shows the different lymph channels throughout the body. And so we have lymph nodes, and so when you go to the doctor sometimes is attempting to palpate lymph nodes. Lymph nodes should not be palpable. If we have palpable lymph nodes, that is something that has to be followed up with a physician. Lymphedema is the accumulation of lymph in the soft tissues. And so the difference between lymphedema and lymphangitis is that lymphangitis hurts because it's an inflammation. But with lymphedema, this is the accumulation of fluid in the soft tissue. And so again, the lymphatic system is responsible for removing bacteria and also helping to remove excess fluids. But with lymphedema, we see that the person has fluid to develop in an area. It's commonly seen in a patient that has a mastectomy. When a patient has a mastectomy, then the lymph nodes associated with that breast may also be removed. And so if the lymphatic system has been removed on that side, then fluids will accumulate in that side because we've removed the mechanism of moving fluid and debris from that side, which brings us to the point of no sticks or BPs on the side of a mastectomy. If we don't practice aseptic technique and we try to start an IV on a patient on the side that a patient has had a mastectomy, then we increase their risk of infection because they don't have the lymphatic system functioning on that side of the body to adequately remove or kill those bacteria. And I'm going to stop here. Lymphoma is a disorder that we're going to talk about, that you will discuss in 202, associated with, well, no, actually it's in 202, I'm sorry. So we will go over that in 2 semesters. And have a good day. Thank you.